Good morning, good morning, good morning. Welcome to day 2 of our Hepatitis Nurses Conference. It's great to see you all here, all looking very bright. We've obviously all found somewhere to get a good coffee on the way here in Wellington, the home of good coffee. So just a couple of little things that I wanted to discuss very briefly. It came to our attention last night that our name badges only have our name on them, and I think apart from the educational component of these sessions, I think a huge part of it is the benefit of networking. And I think it makes it easier when you're mingling at the tea breaks to sort of know who the other person is, not just who they are, you can see that, but you know where they work, what's their context. So if I can get you all to take out the bit of paper inside your plastic and write on it whether you're a GP practice nurse, a prison nurse, or a hepatitis nurse specialist, for example, and then state whether you're Christchurch or Hamilton or wherever. So that it just facilitates that ability for people to connect with their local resources. And further to that, we've got a lot of primary care nurses here, and we've also got a handful of specialist hepatitis nurses from different hospitals. I'd like those nurses to stand up. So you guys, specialist hospital nurses, Nicola, Lauren, Hamilton nurses, and are there a couple of others from around the country? So these guys are your specialist nurses in your local regions. And very quickly, if you ladies that are standing can just say which city you're in.
Christchurch Hospital. I'm from the Midland region. Whanganui, Hawke's Bay.
Invercargill at the front, Tauranga, Dunedin. So for all of you practice nurses and prison nurses out there, come up and meet these people in tea breaks. These are your local resources. This is your phone a friend, particularly around the hepatitis C. I hope you guys have all got business cards. You can hand out your number. I'm trying to drum up business for you here. Particularly around hepatitis C. Around hepatitis B, it's our staff that are the port of call for you to help, to be on the end of a phone from your GP practice, from your prison, if you have any questions about Hep B. And also I would get Amanda and Karen to stand up. Are they here or are they outside? Okay, the two people outside are Amanda and Karen, and they are the admin staff from the foundation, incredibly knowledgeable about referral pathways and systems and processes in Hep B. So again, any questions relating to Hep B, please talk to any of our nurses or Amanda and Karen. Thank you. The microphone, when we do question time, the roving mic will come around. It's for two reasons. It's so that we can hear you, other people can hear you, so they know the question's being asked, but it's also because it's being recorded. So when you're using the handheld microphone, if you can actually hold it relatively close so it catches what you're saying. Further piece of housekeeping, just with the planes that were delayed yesterday, a number of you had to get your own taxis into town, and they will be reimbursed. If you could just see Kelly with your receipts, and she can arrange for those taxis that you might have had to get yourselves to be reimbursed. Okay. And I'll just again get you to turn your mobile phones to silent or off, please. All right, so moving on to the first of our educational sessions this morning is Professor Gain speaking on hepatitis B and C, reaching the World Health Organisation elimination of viral hepatitis targets by 2030. So Professor Gain is Professor of Medicine at Auckland University and the New Zealand Deputy Director of the New Zealand Liver Transplant Unit. He's also an investigator for many international clinical trials of new therapies for chronic viral hepatitis and has published almost 300 articles. I'd love to say I've read them all, Ed, but unfortunately I haven't. Ed chairs the Ministry of Health Hepatitis C Implementation Committee, and last year was awarded New Zealand Innovator of the Year for his work towards eliminating Hep C. So it's our great pleasure to have you here.
Thanks. Okay. It's great to be back in Wellington, just for the coffee. It's great coffee. And the latest medical evidence is you can drink up to 8 cups of coffee a day and it's still good for you. There you go. And it's very good for your liver. So I'm going to talk today, I think, try and make it certainly exciting, and towards the end I'll talk about eliminating hepatitis B, which is going to be a huge problem for the next couple of decades. But first of all, how are we going to eliminate hepatitis C? And so is it actually a reality or a dream? And I'll show you it's a reality. These are my disclosures. The opinions I express today are largely my own, all my own, so you can take them, some of them with a grain of salt. So what's the basis of hepatitis B and C elimination? Well, it really came through from the World Health Organization made up this idea, and there are a number of global hepatitis reports. I'll just show you the most recent one in 2017 published, and that really looked at the disease burden from hepatitis B and C around the world. And what they showed is that with the huge advances in the management of HIV, including in sub-Saharan Africa, where treatment's freely available, and TB and also malaria, all of those diseases, thank goodness, have declined in terms of numbers of deaths and morbidity, whilst viral hepatitis continues to grow. And as shown here now, viral hepatitis is soon to become the most important cause of, unfortunately, of death from infectious diseases in the world. And already in all Western countries, including New Zealand, viral hepatitis far outstrips HIV by a factor of about 10 to 1 in terms of numbers of deaths. But globally, viral hepatitis is the most important infectious disease. And this led to a number of reports, and this is the Global Health Sector Strategy released in 2015. And to this strategy, 194 countries around the world have signed up to hepatitis elimination, and New Zealand is one of those countries. And for that reason, we're in the process of developing a national plan to achieve this. And what are the targets for these elimination strategies, which every country is supposed to have? Well, the targets are very ambitious, and they're shown on this slide, and I'll just go through them all, because it pertains both to hepatitis C and then I'll come later to hepatitis B. What we want to achieve by 2030, which is only 12 years away, is a 90% reduction in new cases. So this isn't reduction in total infections, it's reduction in what we call incidence rather than prevalence. So we want to prevent new cases of hepatitis C and hepatitis B. And I'll show you that we're on the track to do that already for Hep B with vaccination. But of course there's no vaccination for hepatitis C. So for hepatitis C we really need to follow harm reduction strategies. And you're going to hear from Catherine Leaf later on today talk about how that can be achieved in New Zealand. So 90% reduction in new infections, an 80% increase in people who need treatment getting treatment. And for Hep C, that's 100% of people. So 100% of people with Hep C need treatment. So you're talking about 80% of people being treated. So in New Zealand, where we think there are 50,000 people infected, that's 40,000 people starting treatment. We're a long way from that target, but we want to achieve that by 2030. And a 2/3 or 65% reduction in deaths. I won't show you all the data, but numbers of deaths in this country from viral hepatitis combined, about 400 to 500. We want to see a 65% reduction in numbers of people dying from viral hepatitis B and C by 2030. So those are the very ambitious targets which we really want to get a national plan towards. So let's start off with eradicating hepatitis C. So these are the revised data on the numbers of people infected with Hep C around the world. We think it's around 70 million people around the world. And that includes 50,000 people here in New Zealand. You can see there are 2 million new infections per annum, and that's largely through injecting drug use. But in some parts of the world, it's also through contaminated syringes, which are being reused because they can't afford disposable syringes. Hep C makes up half the liver transplants performed around the world each year, so it's an enormous burden on liver transplant programs like our own in Auckland, where hepatitis C remains the leading cause of transplant in adults. And there are about 500,000 deaths per year from hepatitis C. We've seen an enormous progress in hepatitis C. It was only in 1989 that they discovered the virus as a cause for transfusion-associated hepatitis C. So 1989 was when they discovered the virus, and a lot's happened since then. You've had huge advances in treatment from the horrible old days of interferon, and many of the nurses who work in the hospitals here will be well aware of the side effects of interferon and the very, very low effectiveness, 10 to 20% cure after a year of treatment and misery. But we've gone to DAAs, really a revolution over the last few years, and now we have pan-genotypic DAAs, and we hope to have them here before the end of the year. And with that, we think with these new treatments, we can eradicate hepatitis C. How can that be? Well, you have to look at how effective these treatments are and what's happened. So this is the percentage cure after a course of treatment. This is back in the bad old days when we were treating people with interferon for a year, or pegylated interferon. Pegylated interferon increased the cure rate a wee bit, adding a ribavirin helped, And then you can see the enormous change in cure rates when you added in the interferon-free combinations of pills, what we call direct-acting antivirals. You went from 10 to 20%, up to 90%, up to 95%. And with the 3 pan-genotypic treatments, so these work in genotype 1, but the pan-genotypic treatments, you're achieving somewhere between 98 and 99% cure. It's just extraordinary what's happened within that short quarter of a century. And not only that, is you've reduced the duration of treatment from a year, 48 weeks, down to 8 weeks. I mean, 8 weeks is easy. Anyone can take 8 weeks. This is what we used to give our patients. This is boceprevir, which was funded here as our first protease inhibitor with interferon injections, with lots and lots of paracetamol and ribavirin. This is what we currently use. In fact, there's another tablet. This is for Harvoni. There's another picture for the 2 new pan-genotypics, which I don't have here. So really, what a difference 25 years make. So 98 to 99% cure after 8 to 12 weeks. Really no significant side effects. No genotyping required, and it will increase numbers of people starting treatment if you don't need repeated tests. No on-treatment monitoring required for people without cirrhosis. So finally, you have a treatment which is ideal for the community. And I'll put it here, it's ideal for primary care. And the big drive from the Ministry and Pharmac is to push treatment into primary care, and I'll explain why in just a moment. Can we eradicate hepatitis C from the country, from New Zealand? Well, I think we can. The first pan-genotypic treatment, the first all-oral treatment is not pan-genotypic, it's something called genotype 1 specific Viekira-Pak. Now, the secondary care nurses would have all used this, and many of the primary care nurses would also have used this because it has been funded from October 2016 for use in primary care. It's a bit more difficult. They're about 10 to 12 tablets a day instead of 1 to 3, and you have to take it for 12 or 24 weeks in most patients. A small number can get less than that. But if you look at this as a Pharmac-funded treatment, you can look at the old interferons, the old pegylated interferons, some of the newer treatments here, and then you can see what happened in the 1st of July 2016. Viekira-Pak was funded, no interferon anymore, so no injections, all oral treatment, 10 to 12 tablets a day, but all oral, and can be given in primary care from October. And you can see it's increased treatment uptake by 2,000% within 12 months. A huge increase in treatment uptake. And this is because not only is it easier to take, but it's more effective. You've gone from 10 to 20% cure to 95% cure with Viekira-Pak. But it only works in genotype 1. The other benefit of oral treatment and getting rid of the interferon, as I said, is it can be given in general practice. I think although the numbers aren't as high as we'd hoped, we still have, and my Australian colleagues even marvel at what we've achieved in such a short time here in New Zealand. We have the highest rate of treatment delivery in the community of any country, any high-income country in the world. There's some countries such as Egypt where they're giving a sort of hybrid in the community. But so it's around 35 to 40% of all people being treated in New Zealand are being treated in primary care or in the community, such as in needle exchanges or CADs. And in some parts of the country, such as Northland, you may be aware that almost 90% of people are being treated in the community. And there's a reason for that. They have a special setup where they can fund the GPs to treat. But I think this shows what can be achieved with even Viekira-Pak, which you're stuck with 12 tablets a day, genotype 1 only. So this is really a great achievement within a short space of time, I think. So GPs are treating around 40%, I said higher in rural areas. Patients can apply for a benefit, the WINS benefit. If we have time to discuss this later, we should. The GPs in the northern region can apply for what we call a POACS extra payment, and that's why I think treatment uptake has been so high in Northland. And you can see the amounts people are being paid in different parts of the country. Most DHBs, there's no funding for GPs, but we think the funding is helpful because for this first generation oral treatment, it is slightly cumbersome. The GPs need to see the patients more than once. They need to see them several times during treatment to ensure that they don't have any problems with other medications they're on. But numbers are falling steadily. I'll thank Pharmac, Mina, for sharing this data. And you can see that is an issue, that we are not going to achieve eradication. I thought we would achieve eradication back here when you looked at a 2,000 increase in treatment uptake, but that's for the first year. And by month, you can see that it is declining. And that's happened the world over. You've got these advent of these new treatments, which are fantastic, huge uptake. People who've been warehoused waiting suddenly get started on treatment. And then suddenly the numbers being treated are declining rapidly from around over 200 a month to around 50 to 60 a month. We'll never achieve eradication or elimination with that number. And this is because we're treating the low-hanging fruit, the easy-to-treat patients. And we need to get beyond that. And how do we increase treatment uptake? There are three things we need to do. We need to have pan-genotypic treatment. We need to find the 25,000 we think who are undiagnosed. And we need to improve linkage to care, which to me is the biggest obstacle. So pan-genotypic treatment is needed because half our patients don't have genotype 1. So half of our patients don't respond to the currently funded Vicera pack. So it's about just over half, about 53, 55%, but that's actually getting smaller. Genotype 3 is the largest genotype outside genotype 1, and that's increasing. If you look at new infections in our young people who inject drugs, almost all of them have genotype 3. And that's happening the world over, that genotype 3 has replaced genotype 1 as the number one infection in people who inject drugs. So be aware that this slice of the pie is getting bigger and bigger, not only because we have more patients being treated, but these patients are being cured. So we need to have something which works against other genotypes, and in particular against genotype 3. This is what we can achieve. Sorry, this is Homi Razavi's data. With genotype Vicera pack, treating genotype 1, this is the numbers of people with hepatitis C, numbers of people developing HCC, which is liver cancer. You can see it's going to double before Vicera pack. Numbers of people dying from liver cirrhosis double. When you add in Vicera pack, which is the green line, you have an effect, but it's not much, because you're only treating less than half the population. So it reduces total numbers being infected. It reduces. There you go. But only by about half. So even if we treated all our genotype 1 patients, it's not going to eliminate hepatitis C. You need that pan-genotypic treatment. And this is what happens if you have pan-genotypic treatment. Suddenly, you're going to cure a lot more patients. You're going to reduce the numbers of people infected. You're going to reduce the numbers of people dying. You're going to reduce the numbers of people with HCC, which is liver cancer. So by 2030, you'll achieve all the WHO targets. So we're on the cusp of having a change in treatment in this country, which will enable us to be one of the few countries which will actually achieve the WHO targets by 2030. I won't go into this in too much detail, but this is very robust modelling. So we'll hit them. So that's fine. We have pan-genotypic treatment. I won't talk about the pan-genotypic treatments, but we expect to have them before the end of the year. 8 to 12 weeks treatment, 8 weeks in primary care, and these are having 98 to 99% cure rates. No side effects, and no monitoring needed if you don't have cirrhosis. So fantastic treatments. But we need to find the 25,000 we think who are undiagnosed, about half the total population. And how do we find them? We're currently using a targeted testing approach, which is what we adopted from the UK and Australia, where we use recognised risk factors, saying, do you have one of these risk factors? Have you ever injected drugs? Have you ever been in prison? Have you ever had a tattoo or body piercing outside a licensed parlour? Have you ever had a blood transfusion before 1992? Have you ever had jaundice? Have you ever been in the country, either lived there or have medical treatment in the country which is endemic hepatitis C? Just to remind you, these countries include Eastern Europe, Russia, Southeast Asia, the Middle East, in particular Egypt, where over 10% of the population have hep C. Or the Indian subcontinent, and that should include Pakistan, which again has a rate of hep C approaching 10%. So these are all risk factors. So these we've got 7 risk factors here, which you say, can you sign up to one of these risk factors? If you do, you should get tested. That's a great idea but it's not achieving what we want to achieve. And this is because there's so much stigmatization around the number one risk factor. In reality, the top risk factor, injected drugs, accounts for 98, 99% of new infections in this country. And most people will, despite having been clean since their teens or their early 20s, will not go along to their GP and say, I want to have a test because I injected drugs in my youth. We still have this enormous problem of stigmatisation of hepatitis C, which in fact Australia has managed to get rid of completely. And we need to do that. So targeted testing, I think, will fail. I don't think we'll ever find those 25,000 undiagnosed. What about birth cohorts testing? The US says just screen everyone who's been at risk. And that means what we call the Woodstock era, for those of you who remember that. The Vietnam War era. So people born between 45 and 65 who grew up during a time, the flower power time when using drugs was so neat, so cool, people coming back from Vietnam. It was an enormous increase in narcotic heroin use in particular in the United States. So let's just screen every adult who was born between 1945 and 1965. It's not relevant because the injecting practice in New Zealand and Australia has gone on beyond that. So it didn't finish in the 1980s, it's gone into the 1990s and 2000s. And even in the US, they've abandoned this because you're probably aware, unfortunately, there's a huge increase in heroin use and fentanyl use throughout the US. And that has a sad effect of almost 60,000 overdose deaths last year alone. So they're seeing an increase in hepatitis C again. So this birth cohort screening is just not relevant. We wish it was, but it's not. Really the way to find the patients is universal testing. And this is a French approach. It's actually the approach used in most low-income countries. But France has been the ideal example in a high-income country like New Zealand, where they've just tested everyone. And they think that's the way to find everyone. In fact, they are one of the countries who are going to achieve elimination first because they've found everyone who's infected. And so to have a universal testing approach, you need to have a different public awareness approach. I've just put this up for your amusement. This is a poster which has been brought out by Hazel Hill, who many of you will know from Dunedin, who is changing tack. She says, just trying to get everyone to have a test. If you feel old and tired, come on guys, who in this room doesn't feel old and tired? Get a test, have one test. For this to work, you've got to have a national registry. The ministry is in the room, so I won't hark on about it for too long, but I think if you have universal testing, you need to have it linked to a national registry so you don't retest people who have already been tested or already been cured. But I think we're going to move to universal testing. And I'm very excited to see that this month, in a very important journal, the French have brought out an argument to show that universal testing is the only way to go in high-income countries. And when speaking to a member of the CDC just a couple of weeks ago, it looks as though the US are going to go along the same route. So they're going to switch from birth cohort to universal testing, and we need to do the same. Okay, the final problem we need to do is once we've diagnosed people, we need to link them to care. This is a big problem in some countries where they've got high diagnosis rates, but they're not treating or curing them. So if you diagnose somebody, you need to treat them. But in New Zealand, we think 50% of people are diagnosed. Many of those are lost to follow-up in primary care or secondary care. And the numbers being treated are only a tenth of that. We're trying to change that with some look-back programs. So we need to improve linkage to care. After you've diagnosed somebody, get them to start treatment. And almost all of those who start treatment will be cured. So the linkage point is diagnosis to treatment, test and treat. And that's going to be the focus, I think, of the future. Improve linkage to care, take treatment to the patients, not the other way around. These are just a few examples, and you all have examples, no doubt, where you're involved. The Methadone, the opioid substitution clinic at Pittman House, the Hep C clinic at the Needle Exchange in Karangahape Road, East Street, prisons, and the Calder Centre. And I put the Calder Centre there because that's been such a success. Calder Centre is a city mission clinic on Hobson Street in central Auckland, where they look after a large number of homeless people who have a very high rate of hepatitis C. As part of their chaotic lifestyle, they've ended up, unfortunately, impoverished and homeless, and many who have significant psychosocial issues which preclude them engaging with primary care. And the Calder Centre shows you what can be done. And I know that similar projects are being set up in other missions around the country, and Jenny's got a wonderful example in Christchurch in her community clinic. But the Calder Centre treats people with Viekira-Pak, this difficult to use treatment, but very effective treatment. And I've treated now, I think I should update that, to almost 100 people who've been treated with Viekira-Pak. And to date, everyone who's been treated has been cured. And these are thanks to a very dedicated bunch of GPs who, with their pharmacists, give daily dispensing for the patients who are sleeping outside, and they're getting them through treatment and curing them. Just shows you what can be done if you have a dedicated staff. So we need to improve linkage to care. I'll argue, not that any of you in the room, I hope, need convincing, that it's safer to treat people in the community. In particular for Viekira-Pak, where the patients, what their comorbidities are and what their other medications are really important for determining how safe that treatment is. And the GPs and practice nurses know what they're on and know what other treatments are on. Patients like it because it's easier, it's not as expensive to go to your GP as it is to go into a hospital, certainly in Auckland. It just costs you have to park there, you've got to queue up, it's a terrible disincentive. You can get added, there are some schemes from WINZ, as I said, to help the patients who are on community services cards as well. And if you get the GPs involved, we get community practitioners involved, you do increase awareness of Hep C and you increase testing. And I'll let Tony Farrell to talk why that's so important. But I think the most important thing about community treatment is that you take away the whole thing of stigmatisation that people face when they come into hospital and sit in the hepatitis C clinic. So we will eliminate hepatitis C, I've shown you that. We will eliminate it here in 2030, I'm confident of that. Worldwide, don't stop here. Treatment's going up worldwide exponentially. And we expect this year over 3 million people will be treated worldwide and will be cured, the vast majority of them. I think it's important to note that treatment rates are going down, as I've shown you, in high-income countries, but going up in low-income countries. Like Egypt, 800,000 people were cured last year in Egypt. Just phenomenal. What you can do if you have a government who are engaged in providing community prescribed treatment in Egypt. And Pakistan and India are also, numbers are going up exponentially. There are 12 countries, I'd like to say there were 13 countries, I'd like to put us on this list, and I'm sure we will get on the list in the next couple of years when people see what we're achieving. And all these countries have the same common factors. They have no restriction to treatment, so they have pan-genotypic treatment. They're treating at least 7 to 10% of the infected population each year, which means that they're diagnosing a lot more than currently. They have very good harm reduction programs. I'll let Catherine speak to that. And most of those 12 countries now have national universal screening programs linked with a registry, and are expanding treatment and pushing treatment into the community, in particular into primary care. So I think Hep C, we will achieve that. Hepatitis B is a much bigger problem for New Zealand. We have 2.5 times as many people infected with hepatitis B. Unfortunately, Hep B kills a lot more people than hepatitis C in this country, as it does across the world. Hep B affects almost 300 million people, so about 5 times as many as Hep C. One person dies every 20 seconds from hepatitis B across the world. So this is a huge health burden. And of course, most of the Hep B lives in our part of the world, in the Asia and the Pacific regions, in particular in the Pacific Islands. To remind you, I'll talk about some of the figures later. So there are 500,000 deaths from hepatitis C. There's over 1 million deaths from hepatitis B each year. And most of those, around 85%, 90%, are from liver cancer. So hepatitis B is what we call a carcinogen. It causes cancer. It causes more cancers than any other carcinogen except tobacco. And Hep B does that just by interfering with our own genes. And once you have chronic infection as a baby or a child, it interferes with our genes and it triggers liver cancer as we get older. So it's a big, big problem. We have good data on who has hepatitis B in this country. Much, much better epidemiological data than hepatitis C. And that's largely through the work of the Hepatitis Foundation And in particular, if you look at Chris Moyes in the room and Sandy, who's really started on this in the early 80s and really have amassed a huge amount of epidemiologic data. And this culminated in the National Screening Program run between 1998 and 2000, where we tried to look at what is the rate of hepatitis B across different ethnic groups in New Zealand. Hepatitis B is spread from mother to child usually, or in the first few years of life. If you or I go out and catch hepatitis B whatever way, today we'll almost certainly get rid of it. So adults who catch Hep B, they get jaundice, they get sick, some of them get very sick, but then they get rid of the virus. The adults we see with chronic Hep B, and those 120,000 New Zealanders who have chronic Hep B, were all infected either from their mother at delivery or during the first few years of life when they went to school and were infected with somebody else, some other child with a high viral load. That's great. It means that vaccination will stop new infections. But we have 120,000 adults in this country who were infected either as babies or as infants many years ago. And they won't be helped by vaccination, obviously. They're stuck with hepatitis B. The one thing we know about Hep B is that it's linked to your ethnicity. And there are certain ethnic groups in New Zealand who have a much higher rate of Hep B than European. And these are Asian, Māori and Pacific people. And I've shown you some wonderful data, really this is wonderful data, from the National Screening Program. So Europeans, when I say Europeans don't have Hep B, I should point out the rate of Hep B in Europeans in this country at 0.9% is almost 10 times what it is in Europeans living in Western Europe or North America. So we have higher rates than European, but nowhere near as high as the other ethnic groups. Māori have a rate of almost 6%. Pacific Island people have rates higher, and in Tongan people, they have a rate of 13%. So that has actually, and in Tonga, if you look at the small surveys done in the Tongan archipelago, rates have been around 15%. That's now the highest rate in the world. It's overtaken China and Vietnam in terms of high rates of hepatitis B in a nation. Indians, although that we call them Asian, Indians have a very low rate of hepatitis B in this country, as they do in India. Southeast Asians and Chinese in particular have high rates of around 9 to 10%. So these are the high risk groups in your practice, Māori, Pacific and Asian New Zealanders. And these are the ones, and these numbers are increasing from immigration. I can show. This is from New Zealand government stats, New Zealand, website. You can all look at this. It just shows you that, as you know, that the ethnic mix of New Zealand is changing. Nowhere else would you see it more than in Auckland, where I went to a joint PHO meeting last month, and they talked about Māori, Pacific and Asian certainly overtaking European within the next 15 to 20 years in the greater Auckland region. But this is a national phenomenon, and so you'd see around 30 to 40% of our population will be the ethnic groups at highest risk for having chronic Hep B. So the Hep B, I think, is going to continue to grow as a disease burden in this country, so we need to look at better ways of treating it. And I think we're already seeing that. We have attached to the transplant program in Auckland, we have what we call a national hepatoma, which is the name for liver cancer, a national hepatoma service, where people from around the country, such as Alex and Tauranga and people from Wellington and Christchurch, phone in their new diagnoses and discuss them at a multidisciplinary meeting each week at a very, very early hour of the day, I must say. But we hold this on a Tuesday morning. And you can see the numbers of people being referred for management of liver cancer over the last 20 years. It's rising and rising. A lot of the early part, was from increased awareness, but from here it's continuing to go up. And that's because we're actually seeing an increased number of people coming into this country at risk for hepatitis B related liver cancer. Now, eradication of hepatitis B is easy. We have a wonderful vaccine, and I could wax lyrical about the vaccine for the next 30 minutes, Chris will do a better job than me because he's been more involved in getting this rolled out across the country. But the Hep B vaccine is the most cost-effective medical intervention known to man. It costs around $20 to save a life with a vaccine by using neonatal vaccination. That means every baby gets vaccinated following birth. It's incredibly effective. It's about a 99.5% success rate if you give it early post-birth, and if you give it on the day of what we call the birth date, and whether the mother has Hep B. And it's really got rid of childhood infection of hepatitis B in this country, which is great. But it's going to take another 90 years waiting for the vaccine to do its stuff. And that's because we have this large population of 120,000 people who have chronic hepatitis B, and we have large immigration from countries where people have been infected with hepatitis B, where their vaccination programs have come on much later than ours. So ours started in 1987. So we were one of the first countries in the world to have a neonatal vaccination program, about the same time as Taiwan. If you look at China, it didn't start until the early 90s, and other countries like Vietnam, Pacific Islands have been the late 90s. So it's going to take another 90 years to eradicate hepatitis B. I think we're out of batteries of this, but I can walk over here. The current status, better vaccination, burst dose vaccination, which is when you give the babies to mums who have Hep B the vaccine as well on the first day. And that's very important for the midwives in the room. I'm not sure if we have any. That if the mother has Hep B, that the baby gets the first vaccine the day the baby is born. If the mother doesn't have Hep B, it can wait and go into scheduled vaccines. So it's going to take 90 years to eradicate hepatitis B. That's just not good enough. The vaccination also won't affect mortality much, because we've got these 120,000 people living with Hep B who are at risk of dying of liver cancer. Around 30% of them will die of liver cancer during their lifetime. This is an enormous burden, and vaccination won't change that. It doesn't work if you already have Hep B. So we need to have better ways to treat people with Hep B. And I'm not going to go into too much detail, but we have the two best oral antivirals available and funded in this country. And I think Chris spoke about this a bit yesterday. I'm not going to go into the guidelines too much here, Chris. But these are the guidelines from the three regions in the world, the up-to-date guidelines. The Asia-Pacific at the top, the European in the middle, and the American on the bottom. TAF, I should just say, is just another form of tenofovir. It's tenofovir with a different formulation, so included as tenofovir. So entecavir or tenofovir are the treatments which are currently recommended first line for treatment of hepatitis B. Both of these treatments are now fully funded without restriction in this country. In fact, we recently moved on July the 1st from the branded drugs to the generic drugs for a 90 to 95% cost saving. And that has, I think that will help with treatment uptake, and there's also a move towards more widening access to treatment by removing some of the restrictions which previously existed. So entecavir and tenofovir are now fully available here. There are guidelines, and the guidelines are here. We're not pushing for this to be started in primary care, but if GPs lived in the if they had experience with hepatitis B or wanted to be mentored, I see no reason why they couldn't start treating patients. In particular in isolated areas like the East Cape, Northland, some other parts of the country where you may have a large census with hepatitis B. So we have the best treatments. Already, we've had them for some years, but now they're generic and more available. But the problems with our current treatments, and this is just to whet your appetite with what's coming in the next 5 to 10 years, I think, is entecavir and tenofovir are great, but they're lifelong treatments. And there's always a risk of lifelong treatments causing toxicity, and we know that tenofovir can cause toxicity as people get older. In the over 60-year-old, there's a risk of kidney disease or bone disease. Many countries can't afford lifelong treatment. Some countries only fund it for a year and then they have to stop. My biggest issue is non-compliance. When I see a young, and I'm not trying to overgeneralize, but I see a young male, Māori Pacific, Asian male, in their 20s and say, we're going to start you on a treatment, you have to stay on this for the rest of your life, I know there's a good chance that that person will stop their treatment over the next few years. And when they stop, if they've suppressed the virus, the virus rebounds, they get very, very sick, and they can actually die from what we call rebound and hepatitis flare. And we see people referred for transplant about 1 or 2 a year because they stop their treatment. And the final thing is lifelong treatment with these drugs doesn't prevent liver cancer in everyone. It reduces it by about a third to 40%, but it doesn't prevent it. So you can still take entecavir or tenofovir for the rest of your life, but still get liver cancer. So we want something better than that. What we need is a cure. And what I mean by cure, I mean a treatment you give for 12 or 24 weeks and you stop it. And the person's got rid of the Hep B, they don't need to take anything else thereafter. And this really is just what's coming, so I won't go over this in too much detail, but we are currently working on a number of drugs which are looking at cure. What we're looking at now is what we call functional cure, which means you put somebody on treatment for 12 or 24 weeks, you stop the treatment, and they don't have hepatitis B in the blood anymore, they don't have what we call surface antigen, which is a marker of Hep B chronic infection. So Hep B cure, functional cure, is what we think we can achieve. And we're starting to achieve that with some combinations I'll show you. The patient's not really cured, they're just in what we call long-term remission. The virus is sleeping in the liver, but it's not replicating, there's no surface antigen in the blood. What we'd really like is complete cure, which is slightly different. You get rid of the hidden, what we call the hidden reservoir of hepatitis B, and then you don't have to follow them anymore, and their risk of liver cancer goes down significantly. Complete cure is probably a bit further along the line, but I think we've got functional cure within the next 5 years. We've already achieved it in a small number of patients in our trials, and it's incredibly rewarding to actually see it happen after a few weeks of treatment. Okay, so hepatitis B cure. This is what's coming. It's something where you can get rid of surface antigen, so you don't have to monitor these patients anymore. The foundation can discharge them if they're truly surface antigen negative at a young age. Currently, when I talked about entecavir and tenofovir being freely available, we currently only treat these patients. I can't do it. We only treat the patients in the middle. And that's about 30% of all people with Hep B actually fulfill treatment, what we call e-antigen positive or e-antigen negative chronic hepatitis B. That's a term which means active inflammation. What we'd like to treat is the other 70%, people who have infection without inflammation. Because you can still, even if you have infection and don't have inflammation, you can still get liver cancer. As I pointed out, it's a carcinogen. We want to treat everybody with hepatitis B, regardless of whether they have abnormal liver function tests or active liver disease or not. That's what we want with the hepatitis B cures, and that's what they're aiming for. The barriers to cures, I won't go into this too much detail, but the part of the problem why we can't cure Hep B, like we can cure Hep C with 12 weeks or 8 weeks of treatment, why we can't cure Hep B is because it has a high viral burden. When you're infected with Hep B, you'll have something like 1 million or 1 billion or sometimes 1 trillion viruses in every milliliter of blood, much, much higher than Hep C. And also the Hep B is a clever little virus. It's been around for a long, long time. I think it was found in some Egyptian mummies. It's been here for thousands of years, and it's evolved to evade our immune system. So the Hep B paralyzes the immune system of babies. So when babies get infected from their mother, their babies cannot clear the virus. If you get infected, as I said, as an adult, you can clear the virus because your immune system's mature. But as a baby getting infected, the virus paralyzes the immune system. If we can somehow fix the immune response and reduce the viral burden, we will cure hepatitis B. And this is the whole premise for all the Hep B cure research which is going on around the world, including a number of programs here in New Zealand. So reduce the viral burden, activate immune response, the normal immune response the person has. And this will really blow your mind, the next slide. These are all the drugs we're currently working on. Not all, but all the classes of drugs. Drugs which reduce the viral burden, what we call core inhibitors, entry inhibitors, siRNAs. These stop release, nucleic acid polymers. So these are all in development. And then there are drugs which activate host immunity. And I won't go through them all, but you'll look at one of them, anti-PD-1. You may have heard of PD-1. It's a monoclonal used to treat melanoma and used to treat lung cancer. We did a trial with anti-PD-1 in combination with one of the other the purple drugs, I can't tell you, I'd have to kill you, but we did cure, we saw the first cure. So that by both reducing the viral burden and activating the host immune responses, you can cure patients. Not everyone, and we're trying to work out better combinations to cure them. So it gives you an idea how much activity is involved in hepatitis B cure. It's hepatitis C 10 years on. It's just phenomenal. So we will achieve there by combining drugs which do these three things. And the studies we're currently involved in, and we're about to start, involve combinations of these. I won't talk about them in detail. But we're combining 2 or 3 different drugs together in people with chronic hepatitis B. Okay. So hepatitis B cure with these newer treatments, novel treatments, is coming. I think they'll be here in 5 years for what we call functional cure, for complete cure, probably 10 years. And they have to work by both improving the person's immune response and reducing the virus. But for them to actually work and help us eliminate hepatitis B around the world, they have to be safe. They have to be like our Hep C treatments. They have to be effective for everyone with Hep B, not just the 30% we're currently treating. They have to be short duration, I say really less than 6 months. And they have to be convenient. Oral, I think, is the way to go, as it has been for Hep C. And they have to be affordable. There's no point eliminating hepatitis B in New Zealand, North America, Australia, given that 95% of the population lives in Asia or the Pacific Islands. These have to be treatments which can be rolled out in Tonga, Samoa, Vietnam, throughout Asia. So these Hep B cures have to fulfill all of these requirements. So I think we're in a very exciting time for viral hepatitis research in the next 5 to 10 years. And I can tell you, having used many of these drugs, that in combination they do work. And they will prevent deaths and save costs, even despite the neonatal vaccination program. So that's what, this is numbers of people dying from hepatitis B. Vaccination's pretty good. Numbers will go down as vaccination kicks in. But if you add in oral antivirals to everyone who needs it, this is tenofovir and entecavir, you reduce the numbers of deaths down there, and if you add in cure, it reduces it further. But the biggest change is in cost. If you have a hepatitis B cure which works for 12 or 24 weeks, you'll reduce the cost of eliminating hepatitis B worldwide by about $5 billion. And that's why the governments are so interested in promoting hepatitis B cure strategies after hepatitis C. And WHO has accepted that hepatitis B cure, these new novel treatments, will be part of the elimination strategy going forward. It's pretty... Okay. So to finish on the salient note, why must we eradicate or eliminate hepatitis B and C? Well, I think it's obvious. The patient benefits. I've shown you some data that treating hepatitis C and B prevents cancer. It reduces the need for transplant and reduces death from liver-related causes. There's now very good evidence that hepatitis C, chronic hepatitis C infection, as people get older, it increases their risk of heart attack and stroke. And it does that in the same way HIV did before we had good treatments for HIV. It causes inflammation in the blood vessels, and that leads to heart disease and cerebrovascular disease. So there are other non-liver benefits of curing hepatitis C in particular. People who are cured feel better. I'm sure you've all treated patients who've come back and say, I just feel marvellous, my life goes on. I don't feel old and tired anymore. But I think the biggest issue, and this really pertains to hepatitis B as much as hepatitis C, I think hepatitis B certainly also carries stigma in many of the populations around New Zealand and Pacific and Māori groups. Carrying hepatitis B still itself provides a degree of stigmatisation and discrimination. And if you cure somebody of hepatitis B or C, you remove that. Society benefits, this is obviously what the government wants to see. If you have cures for hepatitis C, which we have, and hepatitis B, which are going to be here very soon, you'll reduce transmission, you'll cut off new infections. You'll improve work productivity. I haven't shown you data, but there's good data that somebody who's cured of Hep C or Hep B will actually either work more often or will work harder. And it's very, very good quality of life data have shown that you improve not only the quality of life, but you also improve their productivity. You reduce utilisation of health resources. All of these strategies are cost saving, not cost effective, they're cost saving. For me, I've already seen an increased access to liver transplantation for non-Hep C. Across Australia and New Zealand, over the last 3 years, the demand for transplantation for hepatitis C-related liver failure has dropped by 50%. Across Europe and the US, the total numbers of transplants for hepatitis C have dropped by almost 40%. And what that does is that makes donor livers available for people with other diseases who don't have Hep C and Hep B. But globally, eradicating Hep B and Hep C has an enormous cost saving of estimated to be $800 billion cost saving worldwide between now and 2030. So just to finish, hepatitis B needs to be delivered, treatment needs to be delivered in the community, both for Hep B and Hep C. And so we need certainly primary care engaged moving forward if we are going to achieve these goals. Thanks. Take questions now.
Thanks, Rob. That was a... Thanks, Rob. That was very inspirational. I'm sure everyone learned something from that. We'll move straight on to Tony's talk, and there'll be time for questions at the end of this as a joint session. So just while Tony's getting mic'd up here, Tony Farrell is one of my colleagues from Tauranga. He's a general practitioner. He's been working there for 25 years. Good morning. He's come in. He's a fellow of the Royal College of GPs and a fellowship in addiction medicine. He's worked with opioid substitute clients with hepatitis C for over 20 years and is currently a member of the Hepatitis C National Implementation Committee. Good morning.
Good morning. Nice to see you. Kia ora tātou. Thank you very much for the opportunity to talk to you, and I'm going to spend 30 minutes approximately, and then very keen to take any questions. And what we're going to hopefully deal with is some current sort of issues with screening and treatment of Hep C in primary care in 2018, a bit of a snapshot about how we're doing. So, favourite topic of mine, this is me. I've been a GP for 25 years, and I remember diagnosing my first Hep C client as a locum very early on in my GP career, a lady with raised liver function test, getting a bit jaundiced. I seem to be aware of some training back in med school, and I did this Hep C test, my very first one, and yes, she had it, and she was delighted to have the diagnosis, but unfortunately she died 3 months later of hepatoma. So dreadful situation really. Through one thing and another, I started a methadone program in primary care, probably one of the most reckless things I've ever done, but sort of started by accident really. We were prescribing drugs for withdrawal for people with opioid dependence, and that was actually illegal, so we got visited by the Ministry of Health, who said, well, you're good guys, but it's illegal, so get yourself gazetted under the Misuse of Drugs Act, so which we did, and then we seemed to have an instant methadone program. So that was a large learning curve. I achieved a fellowship of addiction medicine in 2007. Unfortunately, the funding ran out for methadone in 2013, so I'm now really involved in shared care with methadone, so I've got about 22 clients that I prescribe to. I still have another maybe 30 or 40 who are looked after by the secondary care service. I would say something like at least 50% of them have active Hep C, have either had treatment or are waiting for treatment, etc., or having complications of treatment. I have seen patients over the year do interferon, and what a ghastly thing that was. I've seen patients who have had the interferon, cleared the virus, and then a year or two later either develop a really aggressive lymphoma and die, or a gallbladder cancer and die. So the long-term complications of Hep C are very real to me because I've just seen a natural history in a way over the years. And I've previously been on a Ministry Action Group and etc. I'm also part of a Midland group, implementation group for hepatitis C, and I'm currently prescribing with Nicola for a needle exchange service, point of care service, just to see if we can increase access to the Viekira Pak to those who may not want to come to a GP. So that's where I am. Lovely spot, beautiful morning it was this morning. So can we do it? Yes, we should. I'd like to just talk about stigma initially because I think we have to start with the patients, then where we're at with the GPs, what sort of issues we've got in general practice for prescribing Viekira and screening, and what sort of works well, what doesn't work so well, and possible ideas about how we're going to get through this. So stigma, how does it actually feel to have hepatitis C? As you can see, 94.4% of women and 76.2% of men experience some sort of bad feeling as a result of being infected. I had to get this information from nursing journals because I couldn't find much in doctor journals for some reason. Hepatitis C experiencing stigma. So 90% of people, if you've got a Hep C antibody, it probably is a predictive value of you have ever injecting drugs. So as Ed said before, it's the main risk factor, and again, people don't want to disclose that because of the actual stigmatisation of that behaviour. So it actually compounds the whole thing. And stigma also arises from misconceptions about how infectious it is and how deadly it is. And stigma can be enacted, so you might say to your friend you've got Hep C, it goes quiet, or just naturally felt. So transmission-associated stigma, getting it. There's stories about family members using paper plates concerning they would get Hep C from washing the dishes and reusing ceramics. And some people have had to eat their own food separate to their families. Not even swimming, thinking they might pass on hepatitis C, which is like a felt stigma versus an actual enacted stigma. Feeling contagious, because they felt immediately contagious, so it affects their social milieu. And being labelled as contagious, where co-workers might clean up after you all the time. And when you're asked about how you might have got Hep C, it's a lot easier to say you had a needle stick injury than to say that you stuck the needle in yourself. So disclosing, I feared other people's fear of me, a felt stigma. Withholding disclosure, I just didn't want to tell people. And experiencing it after disclosure, again, friends went silent, the dentist double gloves, all that sort of stuff. And then the idea of shame and deserving because of a behaviour that's stigmatised. People feel that, oh, well, I've done this to myself. And also just, unintentional stigma. Please excuse the sign. But, you can have a large Hep C warning sticker on your medical folder and you might give off an unintended message to the patient. The gastro nurses didn't get that for some reason. Dealing with medication side effects. So when people have to go through treatment, how do they tell their boss, a friend saying, it's all in your head, mate. So, there's a lot of things go on. I think it's been useful for me to go through that because I've always thought about stigma, but these are actual examples and it digs down a bit. And then relationship-based, some people, can't really manage the intimacy. There is a very low risk of sexual transmission in relationships, but some people just can't get over that. Some people's spouses just don't want to talk about it. Again, a daily stigma for that person who's infected. And, people withdrawing and becoming emotionally unavailable. So stigma is really important, and it's why our national plan has to be destigmatised right throughout. So please, if you're going to set up Hep C services, think about the ways in which you can reduce the stigmas of people. Right, so raising the discussion in primary care, given it's stigmatised disease. So we do need awareness regarding how common it is and the sensitivities regarding and eliciting the diagnosis. And that can be awkward, GPs are faced with a lot of tasks. There's estimated 257 possible tasks in a GP consultation nowadays. And so to sensitively broach a subject and talk about it is time constrained, and there may be a whole lot of other factors going on where a patient is already distressed, etc. So GPs can find it difficult. I've often asked permission patients first to talk about something sensitive, prepare them. But again, does that stigmatise, you know, the disease if you start asking about it? So one thing that can be done is, as nurses, especially if you're doing blood testing and screening testing, is maybe offer a laminated card of risk factors or potential risks, and say, look, if you've ever had one of these, let me know and we'll take your blood. You don't have to tell me which one it is. And you know, it really doesn't matter now how someone got infected, because treatment is where we're at. We've got great treatment. Viekira really works. It's been wonderful to prescribe it. It is a bit of a fiddle, you know, getting all the paperwork done. But, you know, interferon, 95% of people used to feel absolute crap on it, and 5% could manage it. Well, now it's the other way around. You know, we might get 5% with its side effects, which might be sleeplessness or aches and pains, itching, nausea, etc. But 95% just seem fine, and I'm pretty sure you'd agree with that, Alex. Yeah. So, yeah, try to think about the way you deliver your questions and make it as seamless as you can for people, because underneath there's a lot of negative feelings. So where are we at? Jaime Razavi's assumptions, as Ed has said, we've probably diagnosed half the people, but they're sitting in our computers. And look, I'm guilty of this as well. I've done a lot of Hep C testing over the years, but failed to code in my machine. You know, once I got a diagnosis, I just started the process of either referring or getting them treated, or watching them, because sometimes treatment wasn't available or the patient didn't want treatment. And of course, I had no way of retrieving them. I can go back through my methadone program, but I know there's quite a few other people that I've tested. And I'll talk about some solutions to that later on. So total diagnosed about 23,000. And newly diagnosed in 2017, 910. So we're getting about 1,000 a year. Now, as Ed has said, we lifted some treatment restrictions in 2016, Gen 1s and those with certain levels of cirrhosis for the other genotypes. And so we've been able to get on and start treating. And so we've increased the number of treated patients from 600 in 2015 to 3,000 in 2017. And that's just due to these restrictions being lifted. So as it is said, the national program really needs unlimited access or unlimited restriction to treatment for us to cure this thing. So we've got about 1.15% of Kiwis have this issue, and half are undiagnosed. And there's a statistic there of people in a middle age and Dunedin, about 4.01% prevalence. And Ed showed this slide before, so we started with a hiss and a roar, and we're now heading downwards in the numbers treated. So that's treatment with Viekira. That's for Gen 1s. So what are the difficulties for GPs given the issues for patients? Steve Johnson and others down in the southern DHB did a postal survey of GPs, and it was quite revealing, I thought. 21% of GPs reported at the time they're actively prescribing HCV medication, but 70% indicated that no GP in their practice has an interest in managing Hep C therapy, which I thought was alarming. And so reasons, reimbursement cited as a barrier by 44%. I'd have to agree with that. I mean, to prescribe Viekira, you've got to do quite a lot of assessment around the safety for prescribing. You know, there's certain things that, you know, if a person's got renal impairment, medication interactions, and I'm sure you've all heard of the wonderful Liverpool Hep C interaction checklist. But that takes time, and things have got to be checked pretty carefully, because if your medication list isn't marked as a regular medication and you're taking something like Flixotide and you start someone on Viekira, you can make them Cushingoid without knowing. So it has to be done fairly comprehensively, and it does take time. You've got to explain to the patient all about it, and then you've got to write the Pharmac form, get that sent to Pharmac, and then the Pharmac will then send the pharmacy the medicine, who'll contact the patient And then you've got a wee bit of a communication loop there because you really want to know when you're starting the treatment so you can monitor if you need to, especially on ribavirin. And also just to know that the patient has started in compliance and all those sorts of things. So you need reminders on top of reminders, and patients don't always go according to schedule. So there is a lot of work in it. So I think reimbursement is an important aspect, but not the only aspect. So caseload is another issue. 40% say they don't have enough hepatitis in their practice to warrant it. Well, I think they haven't looked. And 40% just say they're too busy. And I think there is a real reality of a 15-minute consultation now being just jammed up with multiple patient requests and multiple bureaucratic stuff to get the treatment going, to get people access to treatment. A lot of people are saying not enough access to FibroScan and training. People wanted, or GPs wanted more training. And attitudes. A lot of GPs felt it should be a specialist disease, and that may be a traditional thing as it was, but we really need to be emphasising the cure is going to be in the community. So increased funding is unlikely to be successful just by itself, but if you add in some good support and good education and get those attitudes sorted, we can do this, no worries. So enthusiasm isn't as great as we'd like. It's in pockets. There's a big disparity of general practice enthusiasm and uptake. And again, for a national plan, we really need consistency and good linkages throughout the whole country. So about 2,000 prescriptions prescribed and 20% with GPs. It's nice to hear Ed say that we're actually, we've got reasonably good community engagement compared to other high-income countries, but I think we can all do better. And again, we've dropped off in 2018, 216 prescriptions for Viekira Pak and 108 by GPs and 153 by secondary care. So we really need our GPs engaged to significantly head towards cure. So what's working well? They are plenty. Basically, this graph shows the percentage of primary care prescriptions for Viekira Pak and as opposed to the secondary care. And you can see that it went well in the Bay of Plenty. Now, a bit of that may be because of the 2 methadone services, but I think a lot of it went down to some really good education sessions. Some really good coordination of information around Viekira Pak, GPs getting along to evening meetings and really thrashing it out. The PHO getting on board. No funding, however, but still with great support from the specialists who are really, really open to being rung and ask questions, and really, really good hepatitis nurses. Again, open to answering questions and just a powerhouse of knowledge. We seem to get a reasonable uptake initially. We also had really good access to FibroScan and a simple GP referral form. So with a local working group, good specialists who really want to get GPs involved and the GP uptake, you can get good results. You can see Northland, it's down about 8 from the bottom. They got about 57% of GP uptake, and they were being paid $300 to treat. Because it probably takes half an hour to really sort out that first consultation for Viekira Pak, and then you've got all the monitoring and adjusting doses and stuff. So, and so I think that's had some impact, but I'm not sure about the other factors that went on. So what's not working so well for screening? Stigma, obviously, and awareness. And you could see from those attitudes, I don't even think it's very, I have many of those sorts of patients, Incomplete records. I just had a quick look the other day. We've got 78% of patients coded as under a RED code for having Hep C. I know there's a lot more people than that. You would expect that 1% out of our 7,000 patients, we'd have 70. So I guess we've sort of achieved that, but I know because of my service with these extra 65 clients and maybe, you know, something like 60% of those being positive Hep C, I probably should have maybe another 60 people in my practice. So I'm going to work out ways to dig them out. So we've got many more tested and just not able to be retrieved unless the labs get involved and do a look back. And as many patients have been tested for the antibody and not followed up, and I call it data sitting in the electronic wilderness. Now, what isn't working well with treatment? I've heard in some pockets of the country, some specialists are sort of holding on or treating the patients rather than, if they're low risk, not scarred, getting them out to GPs and encouraging them into treatment. It really is satisfying to give someone 12 weeks of treatment and then 12 weeks after that do a SVR and to be able to ring them up and say you're cured. It's just brilliant. And I'm sure any of you have been involved in that realise just how profusely thankful people are about it. GPs aren't actively screening and therefore can't treat if they don't know that they've got it. Some FibroScan services are hard to reach. No funding for the Gen 3s, which is disappointing. So, you know, we've got patients coming in, what my treatments, unfortunately you've got the wrong type. We just have to watch you for a while. You could have the Hep C Fix-It treatment. Have you all heard of that? So basically, in Perth, there's this wonderful guy called James Freeman, I believe, who set up a service of procuring generic drugs from India. And essentially, you can treat a Gen 3 as a GP under Section 29 by getting the patient to pay some money, which is about probably $1,500 to $1,800. You run them through the Hep C Fix-It website, and they'll take all your details, and they'll actually ring the patient after the money's been paid. They get a consult from a doctor in India who says, yes, you've got Hep C, you've got this amount of scarring, you're suitable for treatment. And then once that's done, they will send the treatment either to the surgery or the patient. And the GP or even specialists can supervise that treatment. And I've actually treated probably 3 or 4 people that way. I had one marvellous lady, 73 years old. She just seemed to have no risk factors. She said maybe a bit of rumpy-pumpy. She didn't know. But anyway, she was feeling a bit, you know, sort of tired and stuff. And just, again, really grateful that someone could actually access the treatment. She was happy about the money, and she just ran straight through it, no problems, and she's cured. You know, so that can be done, but again, that takes about 3 hours sometimes to do all the paperwork. You know, they need a proof of identity, a photographed license. Yeah, there's all this, you know, bump to get through, and it just takes time. By the time you fill out the internet stuff, check interactions, etc., etc. So there's no funding for the Gen 1s either, so the actual cost of a consultation. And remember that people will come in talking about Hep C, you may want to treat them, but they might have their hemorrhoids and their depression and their blood pressure and their WINS form to get done. So it's a fair bit in one 15-minute slot. And there's variability in resources and support in different DHBs. So, solutions. I shouldn't really put up alcohol jokes. I am a spokesperson for Alcohol Action New Zealand, but I'm not opposed to alcohol, just the commercialisation of it. Anyway, political will. So what do we need to do globally? We need to destigmatise this throughout whatever point of care we get treatment at. Harm reduction, and Catherine Leith's going to talk about that. Funding, we definitely need a national database and screening program. We need a really good national awareness program to get people and testers keen on picking up the disease. Coordination of care, multifaceted areas that you can go in and get either tested or treatment. I think Australia's done this brilliantly. They've destigmatised all the different services you can go to, and they will pick up your Hep C and either link you to someone or treat you themselves. monitoring and evaluation, and expand primary care and allied health capacity for screening and treatment. So I think nurse prescribing is going to be really valuable here. Once you get through the indications and any risks of side effects or interactions, it's really straightforward stuff to prescribe. I wonder about dentists, especially for screening, and alcohol and drug treatment providers. I was really pleased to hear a psychiatrist at the Bay of Plenty Addiction Services saying she's quite happy to prescribe the Vicuripac, which is great news. It's sort of outside their scope, but also they can become proficient and prescribe, and I think that's a really good opportunity. And we want the new pan-genotypics that Ed's promising in October. So local solutions, what else can happen? So there's this idea of the lab look back. So basically the labs in the Midland area just went back to find old hepatitis C results, and then they sent those results back to the GP electronically with a suggestion that they should do a genotype and a FibroScan. We tried to get it back so that it was sort of flashing a bit for the GP to actually realise it was something that you should act upon. And we got a 9% uptake from that, so that's just one thing that can be done. And there was one patient found with cirrhosis, so that's important for screening for hepatoma and getting on and treating, obviously. Keep it simple, stupid, regional BPAC referral form for FibroScan. Something I was really proud of because I was involved with that. Because I fill out a lot of forms, and you get a dietitian form, and you've got to put the cholesterol in and the triglycerides and everything else, and it takes you half an hour to transcribe back and forth on your screen. This thing, you need an ALT, a genotype, and that's about it, I think. Send it off. And you don't have to write much of a clinical note. The FibroScan service is the service that talks about risk factors or other things that may need to be talked about. So it's really good to take that burden away from the referral source. We used to have Hep C forms that had how many patients, how many drinks is the patient having? Is it one drink 3 times a day? And it was nuts. It doesn't matter. We just want them scanned so we know how scarred they are. Are they suitable for primary care, secondary care? What treatment do they need? What genotype, etc. So a simple FibroScan referral form and easy access to FibroScan is going to be critical. And we've got an e-response where the FibroScan and suggested management plan comes back into the provider inbox. So a provider inbox is a list of 200 results that I have to look at every day. It just comes back from the lab or the hospital, and I'm just going through those during the day, managing abnormal results and filing anything that doesn't need action. So it can be done, and it's just an example of the coordination that's needed. Needle exchange, point of care service. So this is a particularly good way to pick up high risk people. Basically, a lot of people don't necessarily want to come and see a GP, especially around these issues. A lot of people with opioid dependence don't necessarily even want treatment, but they still want help with their health issues, and this is a great way to do it. So it takes a bit of organising with your local needle exchange manager and staff. I think it's really critical that you have a peer support worker there, because we found that a peer support worker really helps the trust, that really helps the patients engage with maybe just getting a finger prick test. So you can get a simple needle stick finger prick testing now for Hep C, which have been validated, sensitive and accurate enough to then give us a result that we can go on and do a blood test for. So one really good way to engage the patients is to give them a scan as well, check your liver out, and even regardless of the test, they do quite like that idea. So you have a FibroScan available, finger prick testing, and followed by blood testing, and the GP prescriber. And this was a revelation to me, because Nicola needed someone to prescribe. I think she's well capable of doing it herself, just not quite allowed to yet. Anyway, so I rang the medico-legal team, and they said to me, because I said, well, can you prescribe to someone you've never seen. And it feels a bit weird. And they said, look, as long as you know that they've been competently worked up and that the person who's in charge of all that has got their way around it fully, you're fine. You're medico-legally covered. So with that in mind, I've been signing scripts that Nicola's been sending me. It's working a treat. And it takes me about 2 seconds. I either get an email or a little packet and just sign it and send it back. And it's quite interesting because I've seen a couple of patients that used to be on my program. They've somehow ended up on the street again or whatever, back into opioid using, not in service, and they've actually been cured of their Hep C, hopefully through me, indirectly. So numbers, we've seen 25 so far. Interestingly enough, those clients didn't really worry about their data being scattered amongst the country. They weren't worried about anonymity. We were unable to get bloods from about 4 patients. We're going to retest them. The people who we couldn't get blood off had low FibroScan scores, so that's reassuring to some degree. One new diagnosis with 5 HCV infections, 1 referred to secondary care, but we've treated 4, 3 males, 1 female, and we've got an SVR so far, and we've got 2 outcomes weighted and 1 still on treatment. So it's great news, really. I mean, those people would not have been treated otherwise. So. Other ideas. I've become aware of nicotine dependence being associated with Hep C and higher rates than people without Hep C. And we do these cardiovascular checks in general practice. We take blood and we do blood pressures and we ask them about their family history. What about the idea of screening for Hep C at that time? And I know Ed's saying universal testing. I think absolutely. But until that time, we need to do what we can. So I'm working on a proposal to link Hep C testing to our cardiovascular disease checks. And I've said there for smokers, but I've just done the numbers for some practices in the Bay of Plenty, and there just won't be enough if we just do smokers. So I think we just link it to the cardiovascular checks and see what we come up with. So what we do there is supply point of care testing, a fingerprint testing to the practice. We'll need a consent form, and we'd test on the spot, follow up with a blood test, and just see what we pick up, because if that is going to be effective, if we pick up 3 or 4 out of 300, that may be something that we can engage on a systematic basis through PHOs and hopefully get some incentives for the practices to do that. Allied health. So this study here talked about chairside medical screening with dentistry, because a lot of people go to the dentist, believe it or not. And in the dental setting, for diabetes and heart disease, which we know is associated with Hep C, it's effective for identifying individuals who are at increased risk of disease yet unaware of their increased risk. And it provides a portal of entry into the primary care system. So this sort of thinking, I think, if we know people are going to be going to allied health practitioners, are they opportunities for checking for this disease? Studies also suggest it's feasible to do this, and at POC's point of care, and it's viewed favourably by the dentists, the patients, and primary care providers, and they're all willing to participate. So we can do this. 70% of Hep C patients suffer dental pain. So there are different ways to skin a cat. And then there's the idea of a mobile needle exchange. This is probably for active injectors, but in a lot of rural areas, a lot of pharmacies are doing needle exchange. There's high numbers in some pockets, and it would be great to have a van that you could rip out, just let people quietly know they're going to be in a certain area. You don't have a permanent sign over the van, needle exchange. You just have magnets that you can put on once you get there and then pull them off again, just to keep stigma down. Again, you do need really well-trained peer workers, because once someone's been diagnosed or been perhaps screened as a positive screen, their reactions can be quite significant. And so one of the things that's become quite apparent through discussions with needle exchange is that peer support workers feel vulnerable about their skills around that, so that there needs to be some input there. 90% of new infections are from injecting drugs. And we've got the wonderful Jo DeLille here. Jo's really driving the Midlands group, and she's been doing wonderful things. She's got a point of care testing going in Hamilton. She's been doing great stuff in Gisborne, because the Tairāwhiti DHB are running a whole of sector eradication campaign. So here we go. The PHO's involved, the DHB, I think the CEO of the DHB is saying, yep, we're going to do this. So it's a priority. NGOs, the lab, they've got a communication person, and they're doing an awareness program. And they're piloting an outcome-based funding on incentivising the providers if they get a viral load, they might get a little bit of money. If they prescribe, they might get a bit of compensation for the time and stress of that. And once you've finished and got the cure, again, just another little incentive. So take the service to the people, and a really good example of passion and goodwill. Now, screening baby boomers, again, universal screening is the one. But just look at those stats there. In the US, 4,000 annual deaths from cervical cancer and 40,000 from breast cancer, 80,000 from Hep C. So it's like Hep C is not a very nice illness to have. You know, if you've got breast cancer, it's terrible, but everyone empathises with that, but not so much with Hep C. So it's quite telling, isn't it, that statistic? And as Ed has said, the CDC's recommended baby boomers, but because of the whole debacle of OxyContin prescribing and Mexican heroin, we have cities with overdoses every hour and a half, I think, in America now. So the opioid epidemic is a real problem, and again, that's going to rise the acute infection rate from injecting drug use. So we have about 10,000 injecting drug users in New Zealand, and there are other infections in this non-currently injecting population. So basically, with 10,000 people injecting, we have, well, another 15,000 undiagnosed who aren't. So actually the majority aren't in that group. And I'll show you an example of that in a minute. So we need a national database and a lower cost viral load to make universal screening cost effective, because at the moment we have so many double ups that the cost of picking up one new case is about $3,000, and you know it's going to be prohibitive. So once we get the double ups down and the cost of testing down, we can do it much more cost effectively. And Ed showed you that before, just a wonderful universal way to engage people feeling old and tired. So I'm apparently passionate about this and supposed to be proactive and aware, and I'm on the committee and all this sort of stuff. So I have this 50-year-old woman who turned up 2 or 3 years ago with benzodiazepine dependence, and she's a strange lady. She's quite, you know, I think she's probably got Asperger's syndrome. She's very, I guess, rigid in her style of communication, and she's anxious, and she's, you know, a lot of work around her sedative use. And I guess I was preoccupied with that. She's, you know, comes from a really good family. She's financed. She's got her own business. She's actually quite functional, but she's got this problem with anxiety and sedatives. And there was all sorts of issues with that. And she finally came in one day and she told me how smart I was looking, and she liked the stuff I was wearing and all this sort of stuff. I thought, hello, you're going to get asked for a whole lot more benzos. And she goes, I got Hep C. And she almost burst into tears, and it just struck me that, you know, I just had no idea, hadn't thought about it, and yet she had addiction, and she's a baby boomer. And I guess I reflected that my focus on traditional risk factors, I just completely missed the boat. And she's Gen 3 and is waiting for treatment because, actually no, she's Gen 1, but she's on Seroquel, so she can't have the Curapac because it'll interact too much, so she's going to wait for Pangenitins. But it was really fascinating to me that I'd been so focused on intravenous drug use that, you know, I probably missed the boat in many parts of my practice. So it's a take-home message that we need to think more widely about this. So, Yeah, we're going to try to treat 7% per annum to get rid of this thing. And the majority of these patients are in the community, and care is a bit disorganised and inadequately funded. And people are coming into various parts of the system, which represents a great opportunity. So we need a well-funded and destigmatised, coordinated and multifaceted public health approach to screening and treatment from a range of providers supported by a national database and national plan. And we need to work together rather than silos, which I think is starting to happen. And as Jim Jeffries says, we can all do better. I don't know if you know Jim Jeffries. You may not want to know him. He's quite rude. So that's me. Thank you very much to Joe and Nicola. Thank you very much. Any questions at all?
Yeah, so thanks, Tony. That was a really good talk. So I'd invite Prof up, and I really want to hear of any questions. So we've got Kelly coming round, so we can just... No, the gentleman at the back, we've heard you speak a couple of times. Give the microphone to someone new.
Later.
Go. I just thought I'd share around the ability for everyone to ask questions.
I currently work in prison. We do all the testing ourselves. We don't ask our GPs to do that. Would you guys do that as well? Would you ask your RNs to print out the lab form, just have a quick conversation with someone? Would you like to be tested?
Absolutely. This is why we've got you guys here, is because nurses can add so much value to this, to the management of this and the diagnosis of this. So absolutely, I would want prison nurses to be very comfortable discussing with the patients and writing these on the forms. And if GP nurses are in a situation where they're handing out a blood form to someone, I don't know what the rules are in GP world.
I mean, often in general practice, a nurse will be talking to a patient, and the patient will want their thyroid done, and they'll just come and make sure that I'm cool with that or whatever. So there's no reason why they can't engage in those discussions.
Oh, because for us, in prison, we actually print out our own lab form. We just sign it on behalf of the doctor. So if they come in and say, I like a test for whatever, and
I think that's fine as long as your doctor is, because it probably a doctor is getting the result back.
We both do. So the nurse that does the print out the lab form, they get a message saying a day or so later, it's now here in the inbox, and also the GP will also have a copy of it as well. But it seems we don't actually miss very many people in our prison, either we're very transient. And also with the classification, we do exactly the same thing at the same time as well. We get the result, we classify it.
So is that the initial health assessment, or is this just
it's both.
opportunistic?
It's both. So we will do initial health assessment if they meet the criteria, or they might just write on a form saying, I'd like to have a blood test done, or they might come in for a cardiovascular assessment. So we do it both, very opportunistic in our prison. Just because we are so transient, we have about 40,000 movements a year, so we're very transient. So we try to get as many people as we can for the Hep B, Hep C, and HIV.
As that poster show, we think people who've been in prison or are currently in prison are a high-risk group, and they will have a higher prevalence in the general population. And we would really encourage prisons to test the majority, if not all, of their clients if they can. We need a national policy, I think. And corrections needs to have a national policy, but you really look after a population who are high risk for Hep C and who should be easy to treat whilst they are incarcerated. And there's good evidence from Australia where they have a what's the name there, in Goulburn prison and a couple of other New South Wales prisons, where they have a Stop C program where they're actually showing that treating everyone in prison is reducing the new infections. So they do testing on admission and testing on discharge, and they're showing a marked reduction in chronic Hep C in people leaving prison because they're preventing transmission.
Gee, we'll punch you now, and then we'll come across over the far side.
Hi, Tony, thanks for that. I was just wondering, do you think with the new pandemic sort of coming out that a lot of these problems that you have identified will actually improve? I mean, will there be more uptake by GPs if there's not as much work to do around the
Well, we could do a straw poll. I mean, Tony said 1 out of or had side effects of Vicaripac. That's all due to the ribavirin.
5%.
Yeah, so with the new treatment, there's no ribavirin either, and you've gone from 12 weeks to 8 weeks or 12 weeks once a day, so none of the difficulties with taking twice daily. So if you have a treatment which is 8 or 12 weeks, has no side effects, there's no monitoring in primary care, how many nurses or other people in the room would treat patients? Put your hand up. Well, do you think there'd be a change? I think there's going to be a change in general practice.
Yeah, I think
If we actually tell people, and the other thing is you don't need to genotype. We pointed out the issue at the moment is you have to genotype. As Tony said, this whole thing about increasing awareness and getting people to get tested comes and falls flat in the face when you say to half your patients, I'm sorry, you have Hep C, but we can't treat you at the moment.
There's one more question. Have you got many Geno 1s that you haven't been able to treat because of the medications that have been on and they're waiting for their vaccine?
That's a really good question. So for those that can hear, are medication interactions prohibiting the Vicaripac treatment? In general, no. That one lady, we could have made some adjustment to Seroquel, but she didn't want to. But I would say that's the exception rather than the rule.
Yeah.
You can manage most medications. That website's wonderful. It tells you to either reduce or not use or whatever. Great stuff.
Entrenched with quetiapine.
Yeah.
It's the dose of quetiapine which matters. If it's low dose, 25 doesn't matter. But if you had somebody now in July who has mild liver disease, who's genotype 1, would you treat them now or would you wait for pan-genotypic treatment? I think that's... Yeah.
Once they're cured,
I'm not sure.
Once they're cured, can they get reinfected?
Yeah.
So if they go back to injecting, they can get
Depends on
reinfected
their
all over
practice,
again.
But there's good data on that. There have been a number of studies when they've been developing these drugs which have targeted people who are currently injecting drugs, and they've looked at reinfection rates, saying we'll have to include reinfection rates long term. There is a reinfection rate, but it is low. It's less than 5% over 2 to 3 years, but it does occur, often with obviously different genotypes. But the other thing which these particular studies focusing on people who inject drugs, they're showing that people do modify their behaviour. If they address one of their health concerns, they tend to re-engage more with harm reduction, they use less frequently, and so I think there are lots of other secondary gains to being treated for Hep C.
And no vaccine for Hep C?
No vaccine for Hep C, and to be honest, the chances of developing vaccine are very, very low.
Could I just add to that? If someone was injecting once weekly and they're not chaotic and not, going to be compliant, you can treat them. So the other thing too is that most drugs of abuse are usually potentiated a bit by Vicaripac, and it's a little quandary as to whether to tell the patients that.
Yeah.
But again, don't be put off by that, unless they're chaotic.
Absolutely. Some people have a conception that current use is a contraindication to Hep C treatment. That is absolutely not the case. And with good linkage with the peer worker, with the hepatitis nurse, that's going to be sort of the key point of call for that person on their treatment. Actually, treating someone who's currently using is a good way to reduce new infections. So current injecting use is not a contraindication to Hep C treatment. I think we had some questions over on that far table. Carly's just coming to the microphone.
This is just addition for the prison, what was stated. It is part of our IHA that we do the blood testing with their consent. Yeah. I have been treating hepatitis C in prison for about 10 years now. I started with interferon, and we have been, in our prison, it's a nurse-led clinic, so we decide and we just consult with, I normally refer to the nurse practitioner in Middlemore. So we really capture those who have hepatitis B and C in prison.
So what do you think the uptake is? It is voluntary. What's the uptake from new admissions?
At the moment, everybody is consenting because we have this health promotion in prison about hepatitis B and C and vaccination and everything. So there is almost say yes for the screening test.
Because I think we need more data. We don't know what the true prevalence is in our prisons. We don't think it's anywhere near as high as Australia, but we know it's much higher than the general population.
We did a project. I did a project with Hepatitis Foundation in Rinmotaka. We screened, and there was just a few. But in my prison, there's heaps. So I'm doing data for all my patients for hepatitis B and C, and when I finish, I'll be able to have some how prevalent it is in our prison. Thank you.
Thanks.
Any other questions? Thank you.
I'm a midwife, and I wonder if there's a place for universal antenatal screening for Hep C. We do it with Hep B. It would be interesting, I would have thought, to collect that data and an opportunity.
Well, Arlo's not here. Arlo Upton, many of you will know. Arlo's looked at both fertility clinics and where antenatal screening has been done. As you know, it's not routine. The pickup rate's been really low, but I think unless you bring in universal screening per se, you're not going to find, the 25,000 people undiagnosed. So I think it should be part of a greater universal screening policy rather than just antenatal. But the question is, would you treat the mother? Antenatal screening for HIV is important because you can do something to mum during pregnancy to prevent vertical transmission. Hep B, of course, you prevent vertical transmission. If the mother has a high viral load, you give the mother tenofovir. For Hep C, we're not at the stage yet where we'd recommend treating a woman during pregnancy with these new treatments. That may come, but certainly not at the moment. Just talk about one thing. We heard a lot about FibroScan, and obviously you have fantastic access to FibroScan in Bay of Plenty, Metropolitan Auckland, Metropolitan Wellington, I'm sure Christchurch and Dunedin are the same, fantastic access to FibroScan, but there are large parts of the country where the access is still poor. And I think you need to be aware that there is a simpler test you can do called an APRI score, and we're in the newer guidelines which are going to come out, we're going to push for primary care to actually perform APRI scores, which means you just do a full blood count test and a liver function test, and it's a ratio between the AST enzyme level, you have to ask for that, and the platelet level, and it's a simple thing you can calculate, and that will tell you whether or not the person is at high risk for cirrhosis. And depending on where you put the cutoff, you can avoid FibroScans in 80% of people who would otherwise have FibroScans. So in parts of the country where there's poor access to FibroScan, we would encourage people to do an APRI score and only perform a FibroScan in the 20% or so of people who are above the cutoff. So there's going to be a lot more at the forefront in the next guidelines when the new treatment comes out.
Hi, Dr. Gain.
Yeah, hi.
I suppose mine's not so much of a question, but one of the things that have come back from a lot of nurses and doctors in the areas that I'm looking after, that's Hawke's Bay,
Yep.
Gisborne is a bit more highlighted lately with the new thing, is that I think a lot of them are confused about who's doing what, where to go for what. And, I said, and I've referred the best as what I know, the information I know, but they're saying we're going on, say, the Ministry of Health website, and we've been told to go back to the Hepatitis Foundation as far as Hep C goes. And it's on, and I myself went back and actually looked on several websites, health websites in New Zealand, and actually does refer hepatitis C people to go back to the Hepatitis Foundation. And then people are confused about also the FibroScans and where to go, and that's come to me as an observation from the nurses and doctors, and so that may be a reason for some of the people not uptaking because of the way that the information is getting across to them.
But that's unfortunate. That's unfortunate. I think it's really a lesson that when the new guidelines come out with the new treatment, it's going to be very much a test and treat. Do a test and treat. And it should be, and if you live in a remote area where you don't have access to FibroScan, do an APRI, which anyone can do just online. You put in 2 values and it gives you a score, and then you treat. The foundation still provides education on hepatitis, and you're still providing some of the FibroScan services around Midlands.
Some of our FibroScan are contracted to the people who've got.
But really, it should be up to. I'm not sure how it works in Gisborne, Hawke's Bay area, but their most areas now have health pathways, which tell you how to access FibroScan or APRI, and ours have just been updated, so we moved to APRI as first line. But it's supposed to be the District Health Board generated pathways. But the pathways should be simple. They should be really simple coming out. So that's it's important to have that feedback.
So is there a local working group like we've got in Midlands? So if you've got someone like Joe who's coordinating it, realising where the holes are, then basically make it happen.
So Hawke's Bay is covered by Compass Health, which covers Wellington in the southern half of North Island, and we've got a Compass Health.
Yeah, I'm the coordinator for the Central Region, and I would say go to the health pathways. They're, the referral forms sit there. Having said that, in Hawke's Bay, they decided not to refer to the community service, so all referrals do go to secondary care there. But definitely the health pathways are the way to go.
And that is a problem, and I think we need to change the mentality where hepatitis C does not need to be treated in the hospital. Although you achieve good cure rates in the patients who go to hospital, the problem is, the large number of people who will not turn up, who will not attend their appointment, who will not come forward for testing because they don't want to go to the hospital. I think the hospital has its place for the complicated patients, the patients who are on multiple psychotropic or anticonvulsant medication, the cirrhotics have to be followed up long term. But everyone else, the 90% left, should be treated in primary care, absolutely. What we'd love is for nurses to be able to treat in primary care, and we would like to think that in the long term this will be a named medication which can be prescribed by nurses, not just nurse practitioners, because the newer treatments you'll see later this year are so simple, so uncomplicated.
Any other questions or discussion points?
Funding, it's really a sad travesty that genotype 1 was the most prevalent genotype in high-income countries like Western Europe and North America in particular, and therefore most of the drug development which happened in the over the last 10 years was in genotype 1 because that was a market, and finding treatments which worked against other genotypes took much longer, and so they've come on much later in the field. For example, the pangenotypic treatments, and there are two pangenotypic treatments, have only just been approved around the world over the last couple of years, so they've occurred much later than the Viekira-Pak. So it's been a matter of when they were developed and when they came on. The pangenotypic, Mina's not here today. No. Oh, Mina's here. Mina, you don't have to say, but I'll be careful what I say now. Mina, I think it's likely to be within the next few months, certainly, and there will be a lot of promotion about it because that will be the treatment ideal for community prescribing. Really is ideal.
Any other questions or discussion points? This is anything that you've heard your GPs talk about, any issues or comments or that you've come across in your practice?
Oh, that's right. Just one of the slides you had that in America 4,000 people had deaths due to cervical cancer and 40,000 breast and 80,000 for Hep C. Did you know the figure for Hep B?
No, sorry.
Well, in America it's very low. I mean, they do have Hep B in America, it's mainly in Asian Americans, but they have much, much lower rates of Hep B than we have. So in this country, unfortunately, we still have quite high rates of death from hepatitis B in this country. Yeah. But America's not a good.
How did you find the fact that there are 120,000 people living in New Zealand with hepatitis B?
How do you estimate? Well, I thought you were going to ask me how do we estimate we have 50,000 with Hep C, which is slightly... But Hep B, we have fantastic data from that national screening program in 1998-2000, where they looked at large numbers, almost 200,000 people were screened, biggest screening program done for hepatitis anywhere, really. And they showed that those rates in Māori were 5.8%, Pacifica around 7 to 8%, Asian 9 to 10%, and then they just applied that to the number of adults of Māori, Pacific or Asian descent in New Zealand and worked out the numbers. I think that's a very safe way to do that. And that was sort of random testing of people with those ethnicities. So we think, and you look at the numbers of people we see with liver cancer from Hep B, and that would go completely with that number as being the denominator. So it's obviously it varies completely compared to which part of the country you're in. We know that rates of Hep B are lower in parts of the country where you have a larger European population. But areas which have a higher Māori population, Northland, Bay of Plenty, Waikato, much higher.
one more question back from the Hamilton team.
Oh, good. I think that's we did. It was a neat experiment. Well, it was an exercise about in 1999. ESR up the road ran an epidemiological modelling with a number of ID physicians. I was involved, plus some people from Australia and some very good public health people from New Zealand and Australia. And we worked out that 25,000 people had Hep C in New Zealand. And then we estimated, based on what we knew about the rate of developing cirrhosis, because in those days you couldn't treat anyone, everyone was progressing, and how many liver cancers and deaths we'd see in 2010, 10 years later. And we found that the numbers, in 2010, fast forward 10 years, the numbers dying would double, more than double that number. And so we looked at what had been done in Australia. We saw they have very good prevalence data. Australia, as we've all said, is destigmatised Hep C. They've diagnosed about 90% of the infected population. Their rate of Hep C in the adult population is 1.1% to 1.2%. If you adopt the same prevalence data, we would be 50,000. And we also think that's going to be accurate because we look at the numbers of people, what proportion are undiagnosed. Unfortunately, everyone with liver cancer from Hep C eventually comes forward because they die from this, or if they're lucky enough, they'll get an operation. And of the people we see with liver cancer from Hep C, and that's between 90 and 100 a year now, half of them have had the liver cancer diagnosed around the same time as Hep C or within the last few months when they've become sick. So we think that 50,000 is probably the real number, and 25,000 are the number who are undiagnosed. It's not perfect, but it's all we've got.
All right. Well, I think that's been a really, really good session. A lot of good discussion. So we might call it a wrap there. Just give everyone 20 minutes for morning tea and the mingling and the networking and meeting your colleagues from around the country. Thanks.